Sinead, thanks for what was certainly the most unusual patient story we've ever had. I purposely didn't want to know what Sinead was going to do before I came in because I wanted to experience it and so on. I got a small bit worried when she started talking about going nude in the earlier part of the presentation. I was wondering where it was all going. I was getting a bit excited as well, I have to say, at the thought of it. But when it came to stitching, I was brought right back to being about 5 or 6 years of age when my mother was saying, this is a skill that you have to learn for life. And she said, you'll always have socks that will need to be darned, and so on. So I was brought right back to being that. I thought what was lovely though about this session was that, hands up how many people have had a needle and thread in their hand in the last 12 months. 1, 2, 3, 4. Oh yes, well, it's reassuring when you find that Dr. John Coulter's had a needle and thread in his hand in the last one. But very few of us have had a needle and thread in our hands. But we all got into this creative experience of taking a word, a meaningful word, which hopefully we'll all see when you stick them up here later on. And how one word can make such a difference to us in terms of getting a clear understanding of a journey or something we've gone through. So you all got quite competitive. I saw some really good, vigorous stitching going on at one stage. There were hands going up this way and every way, which is very good to see. But there was a lovely calmness in the room and a gentleness in the room. And I think that was a great way to start our day. So again, Sinead, thanks very much. It was brilliant. Thank you. Our next speaker is Professor Seamus O'Reilly, and he's going to talk about the treatments in ovarian cancer. Seamus graduated from UCG, University College Galway, in 1988. Excuse me. And he completed his medical oncology at the Johns Hopkins Oncology Centre in Baltimore in the USA. He subsequently became assistant professor of medical oncology there, specialising in drug development. In 1998, he was appointed consultant medical oncologist in Waterford Regional Hospital, and subsequently in 2001 in the Cork Mercy and South Infirmary Victoria Hospitals. He's an active member of the All-Ireland Cooperative Oncology Research Group. He's a member of the board of the Cork Cancer Research, and he's one of our consistent speakers at every one of these events, and he always gives very generously of his time to come along today. So, Seamus, you're very welcome, and we'll hand it over to you again. Thanks.
Thanks very much. Good morning. Please feel free to stitch. So it's quite interesting. Sinead told me that about this, and it's about her project. And I must say, stitching is quite therapeutic. John can quake in his boots about a career change for an oncologist. I want to thank June and Sharon for organising the meeting and for asking me to speak. So I want to focus on the discussion is the treatments for the present, the treatments for the near future, and the treatments for the future. So this is a cancer map of Ireland, and basically the Cancer Registry have done this with all of the cancers that we see, looking at regional variations in cancer. And purple is not good, and a green is good, and white is the average throughout the population. And for whatever reason, in our region, we have a significant burden of ovarian cancer here, and also in the northeast as well. And the reason for this is not clear. In melanoma, there's a melanoma belt in Ireland as well, which runs down along the south and southwest and southeast coasts also. But the reason why there's such a high prevalence of ovarian cancer where we live is not apparent. Ovarian cancer is difficult because it's silent, and it's silent because it starts within the gynecologic organs and can spread imperceptibly to quite an extent. And it kind of goes into two pathways. There's what we call a low-grade pathway, a slow tumour progression here, and these are called tumours of low malignant potential. We generally see them in younger women. The management is surgery. They are not sensitive to chemotherapy. And then there's the high-grade pathway, which is the more common one, where you get changes in the lining of the ovary and the fallopian tubes, and ultimately proceeding to a malignancy, and spread then to involve the bowel and involve the omentum, which is a fat layer that separates the bowel from the tummy wall. And it's this spread that's the problem. because this spread is very difficult to remove completely with surgery, and it's very difficult to eradicate completely with chemotherapy. When we talk about treatment of ovarian cancer, surgery, chemotherapy, and the other modalities go hand in hand. We have similar in testicular cancer, for instance, and in colorectal cancer, but really there's a very primary role between cancer of the ovary and chemotherapy, and that's been recognised since 1934. And so in these studies that have been done, they show that if you had good surgery, your average survival doubled. And the better the surgery, the longer the survival for patients. So this role of surgery is seminal in our management, and it's important because it's this integration of chemotherapy and surgery that's primary. So this emphasises the point about the more you can get rid of with surgery, the better the outcome. So this is, I know I'm overlapping a bit with John here, but if you see the blue line is people where they've microscopic disease, where it's hardly visible at all, and you can see it at 5 years, 40% survival. Whereas the more cancer that's left at the end of surgery, it may not be possible to remove it at all physically, the lower the outcome. So when we combine our treatments together, we sometimes do chemotherapy first to make it smaller so that the surgery can be more successful, or chemotherapy after surgery. And there's a multidisciplinary team discussion about how to coordinate these two most optimally. The nature of the surgery is important because the survival is consistently better the better the surgery. So this is an old study from 2000 where they looked at improvement in outcome depending on whether you're operated by a specialist or a generalist. And you can see here for stage 3 disease, your survival is 25% better at year 1, year 2, year 3 after diagnosis if you're operated on by a specialist surgeon. So that in the last 2 decades, this has become standard of care, and integration into multidisciplinary teams and establishing the timing of surgery and chemotherapy is important. What about chemotherapy? Well, ovarian cancer is blessed in that it's very sensitive to chemotherapy. So when we give chemotherapy, even in patients with very advanced disease, there are response rates of 80%. You can often see response rates of 95%. This would contrast to, say, lung cancer, where you have a response rate of 20%. So it's a very, very sensitive treatment to chemotherapy, and this sensitivity is a hallmark of it, and also emphasises why, when we're working with the surgeon, that there's such a benefit to giving chemotherapy first, because you know you're going to get, in 80% of cases, you'll get a dramatic reduction in tumour burden, and which will facilitate combined care. So this is a large study called the GOG, Gynecologic Oncology Group 182 study, and there's a whole different range of different treatments here. And I'm more emphasising, it's not what's in the laundry list, but it's the fact that there's a laundry list here. And when they looked at this large study, which had about 4,000 patients, they saw that it didn't really matter what treatment you got, because the outcome was the same with all of them. So this tells us that we can select different treatments depending on the patients that we're seeing. So someone, say, with nerve problems, say with multiple sclerosis, we would use drugs that don't damage nerve function, and we can assure them that the outcome will be just as good if they're getting, say, Taxol and carboplatin, which tends to be our standard first-line therapy. So this study here is great because it allows flexibility of first-line treatment, which allows us to be for treatment to be more personalised and take into account other medical conditions that patients have. What about giving chemotherapy into the tummy cavity? Oftentimes the ovarian tumour is limited to the ovarian cavity. It spreads along the lining of the tummy, and this is called intraperitoneal chemotherapy. And this was a large study which came out about 10 years ago, looking at giving chemotherapy into the abdominal cavity in addition to giving it intravenously, which is our standard way. And this is done with a tube that goes into the tummy cavity, and the chemotherapy goes in with one bag, and then it's clamped, left for a period of time, and then it's drained again. And the outcome and this is how it works. When you give the chemo intravenously, which is the first one out here, you get circulation of it within the blood, and if you can see that the concentration of chemotherapy in the fluid is this amount, but when you give it directly into the fluid, the concentration is this amount. So you get much greater delivery of drug near the tumour. And in an overview of a lot of studies, this has been shown to improve outcome. but it hasn't really become commonplace. Concerns about the catheter, about 10% of people run into trouble with catheter toxicity, and there's also been a vogue for different drugs, blood vessel changing drugs, which are easier to use, require less technology. But I think this isn't a story that's finished yet. There are large international studies now combining the blood vessel changing drugs with intraperitoneal chemotherapy. And I suspect that over time it's going to become more commonplace in selected patients. These advances are important. So we see selective use of surgery. We talked about the 1930s and 1970s. Then the addition of chemotherapy here and here, the combination chemotherapy and intraperitoneal chemotherapy. And you can see here that over a time frame of 30 years, survival has gone from 10% of 5 years to 7. The average median survival has gone from 10% to up to 70%. 10-year survival from 10%. So this is a huge advance in cancer care in the lifetime of most of the people in this room, mainly through integration of therapies, integration of surgery with chemotherapy, and then better chemotherapy. After treatment, since most people respond, then they're followed up. And this follow-up varies. In the old days, we used to do this blood test called CA125, but a large English study felt that this wasn't very helpful and showed no benefit in outcome. The marker is great if it's normal, but if it's up, it causes enormous anxiety, and often it can be up without any disease being evident on scans or on physical examination. So you induce enormous anxiety by something. So we've tended to shy away from using it now, unless people are on active treatment. And the reason for that is that there's no survival advantage with it, but the quality of life of patients is greatly reduced by it. We have a similar problem in men with PSA testing, where the level is up. You can't find anything on their scans or tests. They're physically well, and whatever gains you've got in terms of survival with your newer treatments have been totally compromised by the effects of it on quality of life. The serum CA125 often goes up, and then the cancer is detected by physical examination or by assessment, and oftentimes by symptomatology. I'm always amazed at the amount of times we're getting scans, say, on patients for maybe a routine issue in, say, lymphoma, and the patient will know before you walk in with the door with the result what the result is, because they know something is not right. My sewing skills are challenged, but but this I think relapse. So I think this. He really is having a bad day. Anyway, so I think that when cancer comes back, it's transformative. I think it's people talk about cancer being diagnosed being the worst day of their lives. I think when cancer comes back, it's the worst day of people's lives, and personally, it's the worst. Professionally, it's the worst in my time, because oftentimes the patient had stopped becoming a patient and become a friend and an acquaintance, and you can really share their pain on the day, and just but we get to walk away and go home with it, whereas they take it home with them, and the palpable grief that occurs when cancer comes back, and we're dealing now with an illness that is treatable but not beatable, is devastating. And I think we underrate. As you get older in my job, you appreciate it more and more, I think. When you're seeing people in follow-up, the main thing is, if the marker doesn't make their quality of life worse, what you want to be able to do is to pick things up when you can make a difference with treatment. If the disease is too advanced when it's come back, it's very hard to do that, and the outcome with treatment is less. When cancer comes back, you're looking at really sequences of treatment, one drug after another, with variable response rates. So you're looking at time on and off treatment is important. You can see here that the durations between the treatments shortens down, because the proportion of cells that are sensitive to treatment becomes less over time. It's a bit like giving weed killer on a lawn. You put up path clear. If you're Seamus O'Reilly, you put up Roundup on your lawn, which kills it completely for 3 months, as my wife told me. But each weed killer works less and less, and the same applies in chemotherapy. That the benefit becomes less and less over time. There are a variety of different treatment options that can be used. There isn't really a best one, and what you're looking at really is what will be the best one in terms of quality of life. If someone comes in and they have significant neurological symptoms or bone marrow side effects from previous treatment, giving them a drug that causes nerve damage or giving them a drug that causes bone marrow suppression is a bad idea, because you're going to devastate their quality of life. So you need to be judicious in what you treat and hear what happened before, hear where the patient is now, and also just in terms of how their quality of life is going to be tied up. The weekly treatment with Taxol is very good in terms of quality of life from a daily basis, but it ties up people. You know, you need childcare once a week, you're visiting us once a week, you're exposed to people who may not be doing too well once a week, so there's a trade-off with it. When I was started in cancer medicine, cancer was viewed as a disease that was a medical emergency that you could do very little about. You know, people were diagnosed, it was operable or not, chemotherapy was given. And in my lifetime then, cancer has been transformed into a chronic illness, like hypertension, like rheumatologic conditions. So we have a proportion of people who are diagnosed, then they get primary treatment, and either they stay in remission and all is well, which is what you really, really want, or the cancer comes back, and then you're dealing with subsequent treatments and palliative care, and the importance of survivorship is important for all of these, not just for the people who are cured, but also for the people who are living with cancer. I think it's very important when we're dealing with cancer to know the limitations of our medications and the side effects of them, and sometimes it's important to know that when we're trying to do good, we can do harm, and that when you're dealing with a chronic disease, it's the quality of the journey that people have with it that's important, not just the duration. And we say this to our medical students and our trainees to emphasize to them that when they're picking the treatment that they give, it's very important that they listen to the patient and they listen to themselves as regards what they were trying to achieve with the treatment. So one of the problems with us is why we can't do better with treatment, and this is the problem, that cancer is a genetic disease, and this disease is adaptive and selective, and the cancer that's sensitive to treatment at the beginning ultimately becomes resistant because it adapts and changes. This is an Emperor of Maladies. It's on PBS now. It's a documentary by Ken Burns. He did documentaries about baseball, the First World War, the Civil War. He's a phenomenal documentary maker. And this book, Emperor of Maladies, won the Pulitzer Prize. It was written by an oncologist, and it's a fascinating look at the history of cancer medicine, of where things could have been done better, of where things were done superbly. And it's a really good, very well written, beautifully written book about the story of cancer therapies. In our time then, to try and make things better, a lot of work has gone into cancer research. So this is the global cancer clinical trials at this time last year. So you can see in Europe there were 10,000 cancer clinical trials, and this is being compared to the Manhattan Project, where the Manhattan Project was the largest industrial project in the world at its time, and the amount of work being put into cancer research would be equivalent to 3 to 4 Manhattan projects, but not the Manhattan Project was a 5-year project. This would be a project every year, so 4 or 5 Manhattan projects every year in terms of the amount of intellectual capital being invested in it, resources, money. In Ireland we have the Irish Clinical Oncology Research Group, and this is one of the trials we've been involved in, the ICON 8 trial, looking at different treatments for ovarian cancer and how they might be done better, weekly treatments versus every 3-weekly treatment. So there's a very active gynecologic oncology group as part of ICORG, and so there's participation with international trials in it. In these trials, what we're really looking for is a magic bullet, some way that we can switch off the cancer. And this was developed by Ehrlich, the father of targeted therapy. It applies in breast cancer, where you give tamoxifen, an anti-estrogen that switches off the breast cancer, which is driven by hormones. And in melanoma, we've had probably the greatest success. So in melanoma, there's a gene that's abnormal called BRAF, and that drives the cancer. And 60% of people have abnormal BRAF protein, which drives their cancer. And when you give them a drug that inhibits it, this is what the patient starts with to begin with. So here, all these skin nodules here, and it's just like something in fortitude. And then after a week or two, the nodules are gone completely. And so we see these dramatic results in these newer targeted therapies, and this is really the holy grail in cancer medicine, to find these targeted agents. But you can see here that the cancer adapts in a Darwinian type pattern, and the resistant clones, you can see that some of them are up here, then become more manifest and develop. So the plan is to find the targeted therapy and also find the escape mechanism for the target. So for ovarian cancer, what's being done, it's called the Cancer Genome Atlas, where they've taken 12 cancers and they've looked at various omics, genomics, proteomics, metabolomics, to construct a map of the cancer. And ovarian cancer is one of the 12 ones that have been looked at, and it produces a roadmap, something like this. Sinead's going to ask everybody to stitch this before they get their lunch. Anyway, and what they're looking for basically is signals in some patients, about a third of patients, like the RAS mutation in melanoma, that you can develop drug targets for. And what they're finding is that different cancers have different maps. That in melanoma there's one predominant one, and that in ovarian cancer there's a small amount of several ones. The BRCA one is the one that people would know most about, which I'm going to discuss later. This changes in cancer medicine has also changed the way we think about it. When I was growing up, we thought about it as an abnormal cell that was a maverick, but it's not. It's a system. And when we talk to the medical students, we compare it to Anglo-Irish Bank. So Anglo-Irish Bank was a disaster. It cost 3 Olympic Games for Ireland. You could have put 3 Olympic Games in Ireland, and you could have paid the health budget for 3 years for the amount it has cost the state. And cancers like that, it has sustained growth. It avoids growth suppression. There's no regulator financially either. It's immortal. We'll be paying for this thing forever. And it also feeds on other systems. So Anglo-Irish wouldn't have survived without the German banks feeding it, or the French banks feeding it. And these different hallmarks then are also targets. And the ones that we talk about in ovarian cancer are blood vessel formation and these things called the PARP inhibitors, which affect genetic function. So in ovarian cancer, we see a lot of blood vessel development, and this is why a lot of patients present with fluid within the abdomen, which is very disabling. And these drugs called Avastin, bevacizumab or Avastin, switch off that signal, and you can see dramatic responses in patients who come with significant fluid accumulation. And we also see significant survival advantage with it, so that in patients down here in the high risk group, you can see that there's significant progression-free survival, so the cancer stays away for longer, and also the patients live longer who get this treatment. So we've integrated this into our first-line therapy since for the last 3 or 4 years. We also use it for when cancer comes back, integrating it in with the treatment. You can see the yellow line is the people who got the drug, and the blue is those who didn't. So cancer stays away for longer. The quality of life with these drugs is very good usually. The long-term side effects will be blood pressure problems and also kidney problems. So usually we like to give it to them at some stage in their illness. It might be early on, it might be later on. I generally tend not to do it continuously because of the concern about kidney function, and maybe holding it reserved for later on so that you have it rather than using it all up at the beginning or in the middle. In terms of genetics, we often see patients where they've got a strong family history of ovarian cancer or breast cancer or colorectal cancer. This is called the Lynch syndrome. It's a pedigree of different cancers of colorectal cancer and breast cancer and uterine cancer. And in breast cancer, a variety of different mutations are seen. We see the Lynch syndrome and the Li-Fraumeni syndrome, but the BRCA mutation is probably the most common one that we see. And that's the most important one because it's also the most targetable one at the moment. So the BRCA mutation tumours tend to arise in the fallopian tube area here, which is why when you have a patient with a BRCA carrier, it's important not just to remove the ovary to prevent ovarian cancer developing, but also the fallopian tubes as well. And these mutations are found often in high-grade tumours. So sometimes they're there because you inherited it from your mother or father, but sometimes it's within the cancer itself. It may not be in what we call in the germline. It may be in something the cancer acquires. And these mutations are important because they lead to instability in the genome. So just to explain it, if you take the chair you're on at the moment, it's got 4 legs. So if your cancer has a BRCA mutation, it has 3 legs. And so if you knock off a 3-legged chair you can sit on, a 2-legged chair you can't. So if you knock out the 3rd leg using a PARP inhibitor drug or using chemotherapy, the thing will collapse and the cell will die. And so in the PARP mutations, they've looked at a variety of ovarian cancers, and you can see down is good and up is bad. And you can see that in the patients with the BRCA mutations or the serous cancers with the BRCA mutations, in the waterfall plot, they have a reduction in tumour growth. So this drug, olaparib, has been approved in Europe, and it will be available, we hope, shortly for patients who have serous tumours with a BRCA mutation to prevent the cancer coming back as an alternative to Avastin, or maybe even with Avastin. So all of these things are important because sequentially, this is similar to the slide we showed with ovarian cancer survival. But we take survival for all cancers. The 5-year survival has risen in the lifetime of almost everybody in this room from 50% in the United States to 70%. In 1998, when I started working, the breast cancer survival was 65%. Now it's 80%, and it's anticipated to be 90% by 2020. So these are significant gains, slow incremental gains. For many people in the room, the gains aren't quick enough, but there is definite progress. One of the other things we've learned about, like Voltaire, is how aggressively you treat something doesn't. More horsepower. Women have always told men more horsepower doesn't equal more speed. And this is a study where they gave intensive chemotherapy with the medical oncologist and less intensive chemotherapy with the gynecologist. The gynae patients lived just as long, had less hospitalizations, fewer side effects. And we give this to the students to tell them that to be judicious in what they do, that doing more doesn't always make doing better. What about treatment beyond chemotherapy? Palliative care is important. We often use interventional radiology in terms of stent placement or looking at filters to prevent clotting. Interventional pain is very important, and also radiotherapy. And what about hope beyond drugs? Well, I think teamwork and partnership advocacy is important, and prevention and mental hygiene and exercise. I'm just going to touch on a few of those in the last 2 minutes. In a large study in America, they looked at getting the palliative care team involved earlier in patients where the cancer was treatable but not beatable. And they found that the patients lived 25% longer. And I would argue to you that that's better than any of the survival that I've shown you in any of the drug studies that we've discussed today. So you can see integrating the care together can make a significant difference in outcome. And we think that part of this relates to mental health. For every cancer we look at, if people are depressed, they do less well. And that addressing mental health issues, which is probably a strength of palliative care, may allow that to happen. I think the other thing it tells us is that this is from the Tate Museum, the physician, a famous painting, and you can see there's several things in the painting. Sinead could do a lot better job with this than I would, but anyway, so here we go. So first of all, the sense of complete responsibility of the doctor for the patient, the sense of trust, where the mother is standing away, letting the doctor do his work, but there's also a sense of transfer of care of the patient to the doctor. The sense of enormous isolation of the doctor in the situation, which you've all had on call, where you have someone very sick and you're really worried and you just are hoping that they get through the night. And this has been replaced by more a teamwork thing, and how people are looked after now is not just how the doctor is sitting in the kitchen, but how the team behave around them. And so this is an iron wall, and the iron wall is important because it all holds together beautifully, but the bigger rocks and the little rocks are equally important. If you took out the big rock, the thing would collapse, and everybody in the multidisciplinary team thinks of the big rock, but the little rock is also important as well. If the little rock goes, the thing will collapse. And I think that we are often taught in medical school how to work well individually rather than as teams, and I think we need more in medical education in terms of teams. This is just the mental health thing that we talked about. And I think that the other thing that we can learn is from our patients. So this is a book called A Monster Calls. Siobhan Dowd wrote it, but she died from metastatic breast cancer. And this guy, Patrick Ness, who's a kids author, finished it. And the thing in the middle is a yew tree, which is what Taxol is derived from, a chemotherapy drug. And it describes a child's reaction to the mother's illness and death from breast cancer. And it's incredibly powerful. It's not a happy book, but it's a very educative book in terms of what it's like on the other side of the fence, and even beyond the other side of the fence, from not just the person that's sitting across from you in the treatment room, but the wider circle around them. The internet is fantastic as well in terms of support mechanisms. So this is one of the best sites that we know about, the Canadian Virtual Hospice. So if you're a Canadian citizen, you've got a social security number, and you can type in your number here and ask them a question, and they'll send you details about, say if you've got a question, how do I tell my mother I'm ill? How do I tell the kids I'm sick? And they give you an answer within 24 to 48 hours. And it's a phenomenal website, and I think it's a great model for how we could make holistic care more accessible to people. We were talking about the ubiquity of the smartphone when we were sewing earlier on, but the ubiquity of the smartphone also leads to opportunities in terms of access to care. I think the other thing that's important with organisations like this is advocacy and getting patients more involved in what we do. The biggest lesson I've learned in the last 2 months was an email that a patient sent to me who was admitted to hospital with complications from treatment, and who wrote to me afterwards saying that she needed counselling after being under our care for 3 weeks, and the sense of isolation she experienced with it. And while it wasn't a pleasant email to read, it was an important email to read, because it's only with that feedback you can only do better from hearing positive and negative. The negative is equally important. The conspiracy of experience thing I was going to sew on my thing there, but that was not a happening prospect. And but the conspiracy of experience, I think, is a term by Richard Flanagan. I'll just go back a minute. The guy who wrote the Booker Prize winner, and it describes the relationship in a marriage couple between the husband and wife, and what they bring in time, the conspiracy of experience that they bring in life to them, and how they alter each other. And I think that in medicine we probably have a conspiracy of experience between patients and doctors that probably needs more recognition, and that maybe and in terms of health planning, maybe it needs more of the conspiracy of the experience of the patient needs more recognition in the debate and in planning as well, in how we do things, in how we treat people, and how our service develops. How can we do better? I think more multidisciplinary care will definitely, you see from the palliative care service, improved access to care. We still see people who have significant symptoms who have difficulty accessing diagnostic investigations. Our GPs are very concerned about that, and long waiting lists for people where we're worried about something. Cancer research saves lives. We need to integrate it more into standard practice, and it also saves money. My colleague has a trial which will save €3 million to the health budget of the region for patients with melanoma. Our clinical trials unit saves €100,000 a month to the health budget of the HSE in Cork alone, and we would calculate the savings to the region or to the country about 8 million for a service that costs 3.4 million, but also makes care so much better. I think we need more emphasis on prevention. We have an enormous problem with lack of recognition of obesity and smoking in our society, and it would make it very difficult for people to try and lead healthy lives. And I think more awareness of information technology and empowerment. So thank you for your time and attention today.
Thank you, Seamus. Thanks. Isn't it great to listen to someone who knows their subject so well, and to be able to articulate it and get so much information across so quickly? That you must have got a bad burning from Anglo, because Anglo gets an awful hammering every time.
Anglo burnt me because the laptop with my Anglo logo died last night.
Did it? Oh, yeah. Revenge is sweet. Revenge. They're there. They're everywhere. Yes. But sincere thank you for covering so much so interestingly, and while art, Sinead's art is a form of expression, as we've seen. That photograph you showed earlier on with that little two-worded caption underneath it is a fairly significant form of expression in itself. So thanks. We're going to take a break, if we can, for maybe the next kind of 2 or 3 minutes while we set up our next speaker. So if anybody wants to go to the loo and so on and come back, so give ourselves 2 or 3 minutes. Okay, thanks.